Afterwards. So let's begin. I want to welcome everybody. My name is Barbara Else. I'm a research program manager serving as coordinator for the Seed Grant Request for Proposals, or RFP. So welcome to the Seed Grant RFP overview. The University of Arizona Banner Health is a member and program awardee of the All of Us research program led by the National Institutes of Health. The program has a simple mission to speed up health research breakthroughs. The All of Us research program is working to enroll 1 million or more participants across the US to share data that can fuel new insights into human health. By engaging the participation of people and communities who've been left out of medical research in the past and making their data available to a diverse cohort of researchers such as yourselves, the program seeks to accelerate health and medical research to enable individualized prevention, treatment, and care. So let's dive in and go over a few key elements of the Seed Grant RFP, followed by a bit more detail on the research program as a whole, the workbench, and research project examples from our colleagues and guest hosts that are here today, Dr. Jason Carnes and Vinyesh Subian. And today I have Senior Program Manager Sadiq Padel, who's driving the slides for us right now. Okay, let's proceed. And one more slide. So the outcomes of the Seed Grant, similar to the mission, are to contribute to the base of knowledge to inform healthcare strategies and lead to improved health. We are very interested in good work coming out of the Seed Grants, resulting in peer-reviewed journals, and we encourage a dissemination plan for study findings. In that process, as you think about preparing a proposal for the Seed Grants, think about some budget lines related to open access fees as part of the budget planning, if that's relevant to any of your target journals. And also note budget expense limits for things related to like conference travel. We want to celebrate with All of Us research program all of your good work. So it's possible that funded research projects could, we could ask you to be part of our university media channels or All of Us National, possibly, excuse me. And importantly, as part of the Seed Grant program, we want to seek and engage investigator teams to work with us, so help us to help you. Part of that is to use the Seed Grants to help us improve research resources for future investigators, and take advantage of resources and support that are included in the All of Us Research Hub nationally, but also help you locally to have productive and efficient research. Thank you, Sadiq. A few key dates I just want to briefly go over. After today, July 20th, I am available for technical assistance and to refer and triage any questions. So I have virtual office hours pretty much anytime for this program. I'll let you know where you can get a hold of me one more time in a slide that's coming up. Importantly, the proposals are due September 1st by close of business at 5 o'clock. We're going to do a very quick and efficient peer review process on a smaller, simpler scale, mimicking the NIH process. And in the short September 1st, with the target of announcing the awards on September 15th. This is to prepare for an award period that would begin in October, hopefully the early part of October, to allow the awardees about 15 months ending December 24th at the end of the semester 2023. Thereafter, a very short summer report would be due by the end of the month after the new year. And next. One thing I wanted to highlight, and my colleagues will speak to this a little bit more, it's going to be very important as part of your preparation of the proposal to do a preliminary check of the data elements in the public tier view within the workbench. That's publicly available now in the browser, the data browser, to take a look at, depending on what your question is, the condition of interest, what that population size, so it's a size would be, and relevant data categories or elements that you wish to tie to aligning with your research question. Next slide. Quick word on the budget. It's not to exceed $50,000 per proposal. So in terms of budgeting the seed grant awards, the budgets for the seed grants will be integrated into the All of Us award here at the University of Arizona banner, basically as a percentage of the parent award that we've received. Our business person will create sub-accounts for each seed grant award with the parent program. So the business person or contact that you will be sending the reports to the project lead will come from the All of Us program here locally at the University of Arizona banner. It won't be your respective department's business contact. It's important as you prepare the budget and think about it to take a look at your study question and aims and carefully, as best you can, align that scope with the estimated effort so you don't overshoot or undershoot it. And my colleagues with considerable expertise in the workbench may be helpful advisors in that regard. Finally, I want to highlight in the RFPs to take a look at the non-allowable budget items. So international travel expenses are not allowed in the budget at this time. Next, please. The contacts for you and going forward, especially through office hours as you prepare your proposals and think about it for now, and hopefully the future, are myself, Dr. Jason Carnes, who's on the call, will be speaking. He's the program director of the All of Us Research Program Director of Scientific Programs, and Dr. Vinyesh Subian, our Associate Director at CB2. That email address there, aou-research@email.arizona.edu, is your contact email to reach me, and we can triage any questions. Thank you, and let's go to the next slide. So very briefly, let's go talk about a few highlights about the All of Us research program from the big picture. We'll narrow down sort of like an hourglass to the more detail when I hand it off to my colleagues. Next slide. We're looking at one of the largest, richest, most diverse biomedical data sets of its kind in present era. We have tipped over the 500,000 in terms of enrollees. And in terms of the curated data set being uploaded in phases or groups of data in a phased approach, the curated data has 372,000 plus participants in it now, 80% of whom are from underrepresented communities, and 50% are racial and ethnic minorities in the representation. Next. This enables, hopefully, research discoveries that are rich in information and potential. We do this by securely capturing a range of data types: surveys, patient-reported information on lifestyle, access to care, medical history, electronic health records, and there's a very large behind-the-scenes harmonization modeling project to do that, physical measurements, blood pressure, heart rate, BMI, etc. Wearables, right now it's Fitbit devices, and genomics data. I'm going to let my colleagues speak about that a little bit more, but let's move to the next slide. So recently, the first batch of genomic data is uploaded and available in the workbench now, representing over 98,000 whole genome sequences, 165,000 plus genotyping arrays. The section on the right of this slide shows you estimated numbers of the number of participants in the workbench that have genomic data, plus electronic health record, plus physical measurements, plus survey response, participant reported survey responses. And the items below in that sort of tiered triangle on the right show you what those combinations are with different data elements. And next one. When you go into the workbench, there are aggregated overviews, and you can do an interactive preview, which is what I spoke to briefly earlier. There's a simple element there to enter your key terms, such as your condition. I looked up sickle cell and could very quickly see the number of participants that had some kind of report related to sickle cell disease, and where the sources, the main domain sources for those data and participant numbers were. The next one. There are over 2,300 registered researchers in the workbench now. representing over 350 institutions, most of which are academic institutions, but some are nonprofit organizations as well as healthcare organizations, such as Banner. Peer-reviewed articles are hitting published literature now, and we are hopeful and we encourage you strongly to target that as one of your outcomes for your research endeavors. Top conditions being studied right now on the workbench are cardiovascular disease, hypertension, mental health, cancer, diabetes, but there's many, many other topics. And the next slide, please. A related outcome of the large program is to build a diverse researcher cohort. So creating a demographically diverse researcher cohort promotes responsible and ethical use of the data, returns value to participant communities, and accelerates research impact. Also helps us hone in on relevant and key questions of the communities represented in the data set. We encourage student assemblies and early stage investigators to bring their perspectives. I am available throughout the life of the SEED grant to talk about the All of Us program and what we're doing in our region here locally through Arizona Banner Health Award. And I'm happy to come to your seminars, laboratory, graduate student courses, undergraduate courses to talk about the program if you want me to do a lecture module. And we want to ensure access for researchers from various institutions and organizations. For the SEED grant, just as we're starting up to get and build a cohort of engaged researchers, we're concentrating on University of Arizona and Banner Health, but not exclusively. We would definitely want to be including Arizona State University and the neighboring colleges and organizations. Next one. So from here, I'm going to pass it on to my colleagues to drill down a little bit more into the data access and the analytic tools. And they'll talk about a few example research projects before we'll open up for any questions. Thank you much.
Okay, thanks, Barb. So I'd like to give a little bit of an overview in terms of the resources available and what can be done in the workbench and some of the pitfalls that we've learned thus far. First off, Barb has mentioned a tiered access. So there is the public tier. You can go to this website anytime, look at the numbers and get breakdowns of the diversity for individual ICD-9 or 10 codes, availability of labs, even genomic variants. And this, again, I think is a good place to establish feasibility about your research questions, whether enough people are going to be in the workbench that can be used to study the condition that you're most interested in. And then the two researcher workbench tiers are the registered tier and the controlled tier. So one of the main differences is the controlled tier has a little bit more information that could be considered potentially re-identifiable. So things like genomic information. Now, to be clear, re-identification of any participants is prohibited based on the data use agreement, but there is more information in the controlled tier. There's additional training you have to go through to get to the controlled tier. But registration in All of Us is actually fairly straightforward. If you agree to the data use agreements, you do your training, and you create the Gmail account associated with the production environment, which is the researcher workbench, then you should be up and running within 24 to 48 hours. Next slide. Another very critical piece is that this works differently than most biorepositories. So things like UK Biobank, where you can actually download data, that is not the case with All of Us. All of Us is exclusively available on DRC servers from Vanderbilt University. And so you get access. There are pros and cons to this approach. Obviously, you can't use your homegrown pipelines in the HPC and Cyverse. You can copy them over as long as you're using an R or Python programming environment. And everything is in Jupyter Notebooks, so it's trackable, shareable. You can work together as teams and give your other individual members of your team access. It had some kinks in the beginning, but I think it's fairly streamlined now, and many of the kinks have been worked out. But I just want to reemphasize that you cannot download data off of the All of Us. It's prohibited in the user agreement. Again, Now, you can upload data onto it. So if you want to do comparisons with NHANES data or Nomad or whatever raw data you have, you can do that. And again, R and Python are exclusively the two programming languages that are used within that server. Next slide. So, and there's a number of tools. I mentioned the Jupyter notebooks. They have cohort builders. That's a good place to start once you get access. If you want to create cohorts that are based on conditions, repeated instances of ICD-9 or 10 codes, lab values, answers to surveys about healthcare access, about diversity, you can use the cohort builders to do this. Now, the actual analytical piece will need some R and Python programming expertise. And so the cohort builder will only get you so far. And that's one of the reasons that we've agreed to provide some expertise in terms of the health informatics side, in addition to the 50,000 for these seed grants. We recognize that that is likely going to be a rate limiting step in access and utilization of the All of Us data. Next slide. So I mentioned you can upload your data. There are a number of preformed pipelines they're called feature workspaces, where prior projects have been published and are open. They utilize GWAS, they utilize FWAS, making it a lot easier to build that infrastructure within your own teams or investigate, variants of specific interest with your teams. But again, we have uploaded data like the NHANES data for statistical comparison with All of Us data, and that works fairly seamlessly as well. Next slide. And a couple of project examples, and I want to try to go through this quickly, but highlight some of the pitfalls. So what you have to think about with All of Us, and I think Barb alluded to this, is it's really a Venn diagram in terms of what data are available. So you can't expect that every single participant, all 400,000 individuals, are going to have EHR data and genomic data and survey responses. The vast majority of them will have survey responses, but not of all 9 surveys, primarily of the 3 core surveys. And by the way, all the surveys and all of their contents are available on the data browser that we mentioned previously. So really what you have to do is figure out, all right, what kind of data do I need, and how do and what is the union between those 2 data? So if I'm trying to do a FWAS that requires electronic health records of a genomic variant, which obviously requires the genetic data, then I need to make my population the population that has both EHR and genomic data, and that's gonna compromise your numbers some as you drill down further into the phenotypes and the cohorts that you're interested in. Next slide. But that was I think a drawback of All of Us, but I think the major pro to this data set is the diversity. So you're looking at about 20% African American, 20% Hispanic, 10% Asian, and then a large proportion considered as other ancestry and ethnic backgrounds. And so you have now 100,000 whole genome sequences and 165,000 genome-wide arrays on this rather diverse population. And if you work in genetics, you can already see how much of a boon this would be, especially when you couple it to electronic health records information and all the social determinants of health that are contained within the survey modules. Next slide. So this is one project that we did as part of the initial demonstration project. Demonstration projects were really focused on replicating known associations. They couldn't be too novel. That was one of the restrictions. And you can see here on the right how you sort of start with an N, and then as you exclude individuals, as you exclude people who have missing data or they don't have the data of interest, your N's are getting smaller and smaller. There's still substantial N's. Overall, the cohort is fairly massive. But those are the kinds of considerations you have to address. Is, you know, your N is probably not going to be 250,000 at the end of the day. And this was done, you know, several years back, so the N's have grown larger since then. And you can also get a sense of the diversity here. Next slide. And one of the things we did, and I've mentioned this several times, is upload the prior NHANES data. We compared this to all of us in terms of age-adjusted obesity prevalences. And so we did those direct statistical comparisons between NHANES and all of us. If you're interested in obesity, what we found was that the numbers were fairly similar to the estimates in the epidemiologic estimates for that condition, suggesting that the healthy participant bias that exists in, say, the UK Biobank isn't as substantial here, which we would expect, because the vast majority of these individuals are being recruited from health provider organizations, which are large hospital systems like U of A. Next slide. And so it's just some of the major scientific considerations. You have to, of course, you know, be cognizant of missing data. There's going to be missing data. It's big data analysis, so you're going to have you know, missing data. So you can't assume the lack of a value in any field necessarily means that that value is a zero. It's probably missing as opposed to being a zero. There are multiple ways to get to the same variable, like race and ethnicity. There's an EHR variable, there's a PPI derived variable. And so that's important to think about, especially when you're in a team and you're accessing the data set from different directions. You could potentially be using the different fields because there are multiple ways to get to the same data point. There are timestamps for labs and diagnoses. I mean, if you're looking at drug exposure data, I mean, time is obviously an important factor. And again, this patchwork of data sets where you have different people that have different levels of comprehensiveness of the amount of data that they have. Certainly there would be disparate clinical and billing practices between sites. And so your site may end up being an important control variable depending on what you're studying. And then also this denominator problem. So for instance, you can't assume that the individuals that don't have electronic health records data don't have the condition that you're studying, right? If they don't have ICD-9 or 10 code data, then they're probably not going to be, they're definitely not going to be effective cases, and they're probably not going to be effective controls either, because you don't have any clinical data relevant to that individual. And so what we saw in the early going is people sort of used the whole cohort as their denominator and then got crazy results, because really there's about 30% of the cohort that doesn't have any EHR data at all. And that reflects the different ways that the participants could be enrolled in all of us. Next slide, if I even have any more. I think this is you.
Yeah, so Dr. Subian, if you can unmute.
Great. Thank you, Jason and Barb. So I want to follow up on Jason's examples and add two more, one related to adult participants and the other related to pediatric. So this first example is looking at epidemiology of atrial fibrillation. This is also a demo project similar to what Jason mentioned. And we love Venn diagrams in all of us projects. So you'll see a lot of Venn diagrams to look at different modalities in the data set. So here, the big bubble here is looking at EHR data, and the smaller bubble is a survey, specifically the medical history survey. And this is right after we applied the inclusion-exclusion criteria for the study. And for this particular study, it looks like we have more EHR data than the survey data itself. And then once we apply the atrial fibrillation criteria, we have around 3,000 participants with EHR data, and then around 2,000, the ones in the red, are prevalence of AF in the medical history survey. So this gives you a sense of what can you expect in terms of sample sizes when you're using EHR data versus survey data. So as Jason mentioned, your sample size is likely to go down as you add more criteria. So thinking about what are the necessary variables and what modality do you need? Do you need both survey and EHR, or you need just one? Is dependent on your research question. Next slide. So for the same project, how did we characterize atrial fibrillation? So first, in the survey data, there is a specific question asking, has the doctor or healthcare provider ever told you that you have atrial fibrillation? And an S to that question was used for prevalence of AF. In the EHR data, you can see on the right that there's a list of standardized terminologies. In this case, we're using SNOMED codes. These are all of these codes represent AF of some shape or form. So 2 or more instances of AF in the EHR was defined as prevalent atrial fibrillation. So these were the definitions that we used. I want to take this opportunity to quickly demonstrate this. All of you could use this for your proposals. Sadiq, if you could stop the screen share for a couple of minutes. I'm going to share my screen and show you the data browser that Barb and Jason mentioned. This is the public data browser that everybody has access to. So before we started the project, we would go into the data browser, and you can see this is the EHR domain. This is the survey questions. So I'm going to go into the EHR domain. And I can quickly see that there were close to 14K atrial fibrillation, but after applying some of our inclusion-exclusion criteria, that went down. Then you can go in and also look at the very specific questions that we asked in the survey. So for AF, it shows you the exact question that corresponds to the variable. So we encourage everybody to use the public data browser to look at feasibility for your samples, what modalities are available for your research question. And while Sadiq brings the slides back, I want to use the opportunity to also share the context of the study. So the All of Us study is an observational research study. We recruit patients from the community. We also recruit patients from who are inpatients. But given the nature of the study, it's highly unlikely that you will have critically ill or acute cases. So if you have a question related to ischemic stroke, currently the public data browser will show you that there are only 60 participants with ischemic stroke. If that is sufficient for your research question, sure, you could go ahead, but it's unlikely that you will have a large sample for critically ill or acute cases. So that is something to keep in mind. I'll reiterate the point that Jason mentioned, that any aspect with less than 20 participants need to be reported on an aggregate form, and we cannot stratify less than 20. You can stratify by age, gender, race, ethnicity if it's less than 20. Next slide, please. So for this particular demo project, what we found was, since this was a replication study, both the prevalence and incidence of atrial fibrillation increased with age, were higher for males than females, and for non-Hispanic whites than other racial ethnic groups. So you might ask, well, what do these findings or example projects mean to the internal seed grant opportunity and to you? One, it shows that the All of Us data is valid. We have shown through this demo project that both the EHR data and the survey data show comparable patterns for AF prevalence. And there are sufficient sample sizes for most clinical conditions that we seek to study despite missingness. Although your sample sizes keep going down as you apply conditions, you will have sufficient sample sizes as compared to traditional RCTs or observational studies. Given the cloud workbench and how the data is hosted and how the data is standardized and harmonized, you will have less data pre-processing to do. A lot of the data is harmonized and standardized, and more phenotyping to do after you build a cohort which is something that we will help you with if your project is selected for funding. Next slide. Just a quick show of hands. Is anybody interested in pediatric populations or pediatric data? Okay, I don't see anybody, but I'll just quickly go through them. A reminder that all of us does not enroll. Oh, Jasmine says yes. Okay. So all the study as such enrolls people or individuals of age 18 or greater. We do not enroll anybody less than 18, but we do have a legacy or retrospective pediatric data from the EHR. So this particular demo project is looking at the extent of pediatric EHR data. And so we found that we have close to 20K pediatric data as of last year. This may have gone up a bit more. On the left side, you can see the sample sizes for different domains for conditions, drugs, measurements, and procedures. On the right side, you can see the length of care. So the x-axis is the years of pediatric care. So it's going all the way back to 1990. So which means you have 3 decades of pediatric care in the EHR. Next slide, please. So how did we characterize pediatric data? And we picked pediatric obesity, which is one of public health issues, ongoing public health issues. So here, pediatric data is defined as any data type recorded in the EHR after birth, age 0 and before, or at 21 years of age, which is NIH definitions for pediatrics. And obesity in pediatrics was defined as obesity or morbid obesity concepts in the EHR. So the table shows you what are the concepts we used for pediatric obesity. And for BMI measurements with respect to age, that's another domain we use for defining obesity. In adulthood, I want to use this opportunity to highlight that at enrollment, all participants have physical measurements recorded. So this includes height, weight, blood pressure, and all vital signs. So we use the physical measurements at program enrollment. We do 3 measurements for each physical measurement, and we take the second and the third for research purposes. And we also have BMI measurements in the EHR. So these are the domains we use for definitions of pediatric obesity. Next slide, please. So implications for you, if you were to use pediatric data, you have retrospective pediatric data over 3 decades with potential for discovery that may not be possible in any other observational studies or randomized controlled trials. It also gives the opportunity for novel retrospective studies, including any lifestyle or later life traits based on this legacy pediatric data. So those are all the examples we have. So just quick results. So what you see on the screen is distributions of participants. On the x-axis, you have the BMI measured at the enrollment, and we're comparing that to the legacy EHR data retrospectively. And you can see that there is association between pediatric obesity as well as with the BMI measured at enrollment. Next slide. And this is more interesting. We found that childhood obesity persists through adulthood in all of us participants. Even without enrolling pediatric participants, we found that we were able to make this association. So this gives you some insight into what kinds of questions you can ask with the legacy pediatric data. Next slide. There is a repository of all published research studies with all of us so far, close to 50 plus publications, and you can find them at the link on the All of Us research website. Next slide. I believe that's the last. Barb, back to you.
Thank you. Thank you so much. We have a few resources listed here. The seed grant announcement, the University of Arizona seed grant website link, and the RFP link. It's on that website. You can also contact me. I think it's important that we have time if you, any of you have questions or points of discussion, or you want to ask our experts to make time for that. And we do have time for that if anyone has questions. You can unmute and we will entertain those questions. I'm going to change my view here so I can see everyone.
Vignesh, quick question. This is Ritu. Do you have genomics data on the pediatric patients?
If they consented, they should.
So that will be between 18 and 21 years of age, is that?
That's correct. Well, yes, that's only for the 18 to 21, yes.
Okay. Because that's a very longitudinal data you got, like 30 years.
Yeah, for 3 decades, CHR is long time.
There are plans to recruit pediatric patients in all of us, but we're several, well, I shouldn't say several, we're at least a year out from that taking place.
Okay.
So there will be pediatric patients that provide consent down the line, but the infrastructure hasn't been worked out yet.
Okay. Thank you.
Any other questions? While people are thinking, Dr. Carnes or Dr. Subian, can you comment on, once you're in the workbench, knowing that there will be periodic updates to the data uploads, can you explain how that works in terms of snapshot or freezing data sets? A little bit.
Well, there's different releases of the data, and so there is functionality for you to keep working on the same release, right? So there's, for instance, like an alpha 3 release that we were using with the registered tier. While the data is updated beyond that alpha 3 release to alpha 4 or what have you, you are able to still work on the prior release. So I think maybe every quarter we get a new data upload. And so it's a consideration, definitely. I mean, these projects are going to span 18 months, right? And so when the uploads happen and the feasibility established now versus later, it may be different as more individuals get more electronic health records data, and of course we recruit more individuals as well.
I have a couple questions. One of them being, since we're over here in Colorado, we were wondering if there's anything we can do geographically, and we know that that's been de-identified. So we're wondering if there's anything we could do to kind of study the enrollments that have happened Colorado-wise.
I haven't done any of the geolocation research myself. I know we have, at least to a state level, in terms of where the participants reside, and we have the site where they were recruited. Beyond that, I would have to do more research to figure out the feasibility. But geolocation research has been done, but there's always this balance in all of us, like with the N less than 20. The lack of re-identification, all of us is extremely concerned about patient or participant privacy. And so that's one of the reasons why we don't have zip code level geolocation enabled. But I know we have at least state level and we have site. So it depends on the question that you're interested in. And we may have, I think, up to a 3-digit zip code, but I would need to confirm that.
Thank you.
I think, Jason, you're right that there is 3-level zip code, at least for the ongoing phase 3 demo projects. There are a couple that use those zip codes. But it's slightly challenging, Jasmine, to work with geolocations, as you know. So if state level and site level is sufficient, that would be a good place to start.
Awesome, thank you.
So I have a quick question again, and this will be both for Jason and Vignesh. So you guys have looked at the data. Jason said that almost 30% of the recruits might not have an EHR, right? does that mean that they are healthy individuals, or does that mean that we have missing data?
Could be either, right? So
Okay.
this could be somebody who got enrolled at a single visit at U of A, right? They went to Banner and maybe they reside somewhere else.
Oh,
And so
okay.
that's possible that, so they would have just a single visit, right? They would have some EHR data, but not longitudinal. So the other way that patients have been recruited is through direct contract organizations. So people can go into a Walgreens, right? And they can sign up for all of us. And they provide their consents, they provide their survey data, but there's no mechanism for upload of their electronic health records data in that case. And so there's a fair proportion of individuals that either have, very little EHR data, which of course is a consideration when you're trying to establish your denominator or your controls. But there's also just people that aren't ever going to have EHR data based on the way they were recruited.
Okay. Thank you. And I'm just looking at the genomics data and thinking how you can then classify the patients as healthy, normal, unhealthy.
Yeah, the genomics data is a bit interesting in that it's contained within a Hale matrix. If you work in genomics, Hale is a Broad Institute structure that's relatively new. It has some benefits over Plink and VCF files, and you can create those other data structures using the Hale matrix. But it has a bit of a learning curve, which many of our demo project investigators were figuring out. Many of them were unfamiliar with Hale, even though they were experienced bioinformaticians. So that's another consideration. It's a bit of a learning curve, but once you have it and understand the structure, I think it doesn't create massive speed bumps. It's just, it helps to have that expectation when you're first accessing the data. It's not in a structure that is commonly used.
I want to remind everybody, Dr. Pandy's question cued this, that as we proceed with the awards, quarterly we'll be having seminars, and those will be open seminars so that people can ask questions, consult with each other, see what their experiences are, their learning curve. We're trying to build a network of researchers across the entire spectrum as we move forward. So hopefully that'll be helpful in those kinds of sometimes slightly thorny issues, learning the matrix.
I have a quick question. I'm wondering if I've been able to get into the workbench and try to develop a cohort of some variables of interest, but I'm wondering if there's other opportunities for training or just kind of moving along that without a lot of trial and error on my behalf. Do you have any recommendations as we kind of put together the proposals of ways to kind of accelerate that that aspect of understanding what's in the data set and how we can best craft the study aims?
I mean, that's one of the reasons I think we're encouraging the data browser, because it's difficult, right? I mean, there is a learning curve when you're first starting out, and we don't necessarily have a lot of resources to dedicate to the grant preparation side. I will say I'm available for consultation in preparation for these grants. We are, we're planning on having those kinds of crash courses, but I don't know that we're planning on doing that before the end of summer and before that September 1st deadline. So I wouldn't rely on, additional workshops that specifically are tailored towards all of us data. But I also don't know that it's absolutely necessary in the context of the grant application. I mean, obviously it would be better, the more that we have, to submit as preliminary data, including statistical analysis, the better the grant's going to be. But that specifically is why we didn't include it as a requirement. We acknowledge that we think that's going to be the rate limiting step, is access to experienced bioinformaticians and health informatics people that can program in R and Python. And that's one of the things we want to provide as part of the seed grant. But in the meantime, my only recommendation is reliance on the data browser, apart from consulting with us one-on-one, and feel free to reach out.
Yep.
Okay, thank you. That's helpful.
I'll be making available the contact for those of you who are already registered or are going to register for the workbench, some of the resources from the national level. Those are many introductory resources, but they're at the national level for the All of Us research program are building the resources to help with this kind of learning curve process. Part of this is for all of us to help you help yourselves so that you can build.
Yeah, that's
research portfolio.
absolutely true. Thanks, Barb. There are a lot of national resources that are very useful for the structure of the data, how many individuals, getting set up with access. Now, it's difficult to do, an R and Python, workshop around a specific scientific question, though. So it's going to be limited in terms of how much programming expertise you can glean. But it's very useful in terms of the structure of the data that are available, number of participants, those sorts of considerations.
And at least I'll also add that there's featured notebooks on the workbench that you may have seen. Those are very helpful too. If you find a featured project that is related to your question, it might help with better building your cohort. But as Jason mentioned, that's not necessarily a prerequisite for the proposal. As long as you have done some feasibility with the public data browser, that should be sufficient.
Any other questions? As you process all this information and poke around the browser or beyond, and you have questions, please do reach out to me through the email, and I'll see if I can't triage and help you with information. It's very helpful for me in developing essentially the toolkit for research in the workbench moving forward. And I want to thank everyone for joining us and my colleagues for their portion of the presentation as well. And thank you all for registering for this. I want to wish you well and stay cool.
Thank you.
Thanks,
You're welcome.
everyone. And
You're
then
very
don't
welcome.
hesitate to email either me or Barb or Vignesh if you do have specific questions related to feasibility and access. We're happy to provide that feedback.
Can we
Thank
get a
you.
copy of the slides? Will those be sent out to whoever registered?
We can figure something out.
Yeah, we're going to post this video as well, right, Barb? On
Yeah. Yeah,
the website too.
yeah, we're recording it. I just have to figure out the logistics of where we're going to put it. Yeah.
Okay.
But we're going to do that. All right. Anything else? Very good.